Me share my screen and get to, there it is. All right. So welcome everyone. It's great to be able to join you and go through this informational training session for the Natural View Multifocal one-day contact lens. And I think that you'll find as we proceed through this that many of your questions will be answered, but if you have them as we go along, feel free to ask. At the end, we should have time to ask more questions if they crop up. As a little bit of background, I am an optometrist myself. I practiced for 34 years in an optometry ophthalmology joint practice and did a lot of specialty contact lenses and external disease. One of the pluses to being in this setting was that I was able to do clinical studies. And over the time I was there, I did about 30 different clinical studies. That's how I became involved with Visioneering Technologies. They had a need of people to do studies on their product back in 2010. And we started by doing some preliminary studies for them, and it just progressed over the next years. And when it became time for them to start marketing it commercially, they asked me if I would come on and run professional affairs / medical affairs. And I said, why not? It's a great lens. I liked it that much. I said, let's do it. So that's what brings me to this. And that's why I have such enthusiasm for this contact lens. And this is what makes the lens different. This is a unique profile, to say the least. The catenary power curve allows for a very steep aspheric design, which creates a tremendous amount of plus power. As you can see from this diagram on the right side, we're generating about 8 diopters of plus power when you get up to around a 6 millimeter cord diameter. So that is more than enough plus power for pretty much any need that you might have. And so, as I said, we have this very steep curve, which produces a lot of plus power. When you imagine that being in front of the eye, the visual cortex will start to suppress whatever plus power is there that it does not need. That is what creates this optical pinhole, or a virtual pinhole, which creates exceptional vision along this entire EDOF channel without blocking illumination or peripheral vision. So it's a big step up from a standard pinhole. And what it does is take the light entering the eye and creates this long, thin, extended depth of focus channel along which all of the images will be clear. And this has benefits both for myopes and for presbyopes. So we have an elegant design which will give you the opportunity to address young myopes for their myopia correction and for hopefully slowing the progression of myopia, as well as having a lens that will provide excellent vision at all distances for your presbyopic patients. And I would say that presbyopia is probably as big a need as myopia is at this point, because the population is aging and none of us want to give up our contact lenses. And you'll note here that it says one universal ad for all ages. And that is very true. Anything that falls along that EDOF channel is going to be clear. And for that reason, as I said before, the visual cortex is going to extract whatever amount of plus power that patient needs for their reading situation. And I can attest to how well this works. I've been wearing this lens now for a little more than 10 years. My distance power has not changed, but my reading add has gone up more than a diopter. So I am now a plus 250 add in my spectacles. But in that 10-year time, I have not had to change the power of my natural view multifocals. And that's because my distance power did not change. So once you have a person focused in the proper distance situation, the visual cortex will take care of the rest. So it's one and done. And I have 20/15 or 6 over 4.5 vision at pretty much every distance, and it doesn't matter what the illumination is. Bright light, low light, I can see it all, and it's fantastic. And it also provides a huge amount of plus power out in the periphery to give us myopic defocus, which will directly challenge hyperopic defocus and decrease the stimulus for axial elongation. And it does all of these things while keeping visual acuity and stereo acuity at spectacle levels. It's a tremendous, tremendous lens. Now, there are related materials that are available through VTI. If you're white boxing the product, then there may need to be some changes, which Lena can address later. But there are informational handouts that talk about this design that are available. We did a study back in 2024, looking at the defocus curve for the natural view multifocal compared to best corrected spectacle acuity and refractive error. And these were very long visits, took about 2 hours for each visit, because we would take the patient, check their vision, get the best refraction, and then we would check their acuity at distance and near. And then we would introduce a series of different lenses from -4 to +2 at half diopter steps to change the distance at which the eye was focusing optically and assess vision there. And then we plotted it on screens like you can see here. All of these people were mature presbyopes. They had a 2 diopter or greater add for their spectacles. And we calculated the power for the natural view multifocal for each of these patients, and then repeated those same visual acuity tests using the different lenses introduced in front of the contact lens. And we plotted those as well. And what you can see here is that at the zero vergence level, which is distance, the natural view multifocal was actually a tick better than best corrected spectacle acuity in the distance. As you move to the right on this chart, you can see that the near and intermediate vision are also improved over what it was with the spectacles to a significant level. And we're able to improve the depth of focus by 2 diopters for these patients on average, while giving them vision that allows them to read medicine bottles or read very small print on maps at close distances. So it was a very, very good study, showed that we do indeed create a true extended depth of focus design. Now let's consider the difference between natural view multifocal and other lenses that have preceded it. On the left here, you have a concentric multifocal design where you have distance in the center, then a ring of near, another ring of distance, and another ring of near. Next to that, the aspheric design, which also has a center distance in this example. And you can see that they're not quite the same steepness to the transition from the distance to the near, but it's still rather stark. Now, on the far right, we have the neurofocus design of natural view multifocal. And here you can see that there is a very steep but gradual increase in the plus power as you move away from that distance center. And that creates a much smoother transition from distance to intermediate to near. Now, on the left side here in the concentric bifocal, you have your distance portion and then a very steep climb up to your near ring. And you can see that you're basically getting to the near ring when you're about 3.4 millimeters from the center. Now, that's okay if the pupil is larger, but if the pupil is smaller, let's say the pupil is only 3 millimeters, you're not getting into the ad at all. And we'll talk about that a little bit more as we go forward. Let's take a look at this ray tracing thing.
Halos and ghosting often results from competing focus points, which can mean visual dysfunction. Here, the halos and ghosting areas around the focal point in the ring design become more evident. To the patient, these can result in poor vision.
So you can see from this that you have that very bright central point, and that's your distance focus. But the near focal point, which is in front of it, as the rays traverse from the pupil area through to the retina, they diverge once they get beyond that near focal point. And that has the same intensity as the distance focal point energy in this design, and that gives you that very bright halo, which is a problem. Contrast that with natural view multifocal.
Extended depth of focus channel is created by the high amounts of plus power. Reduced intensity means better visual quality and comfort, and fewer halos or ghosting. Myopic defocus area is greatly increased and is enough to reduce peripheral hyperopia, reduce accommodative demand, and address accommodative dysfunction. Here, the halos and ghosting around the focal point are minimal, providing better vision for patients.
So as you can see, a much different profile for the natural view and its neurofocus optics design versus your traditional concentric design. And this again kind of summarizes those two short videos. The light that's entering is going to be about evenly split, as I said, between your distance focal point and near focal point in your traditional bifocal design. And the light that passes through that near focal point and ends up hitting the retina is what creates the halo. Since the intensity is the same, the halo is very disruptive. Now with, excuse me, with natural view multifocal, you have that long EDOF channel, and the light that's emanating beyond those individual points that create the channel becomes very diffuse, but the plus power is still there. And so you get all of the same energy, but it's diffused to the point where the visual cortex can ignore what it doesn't need. And that is very beneficial. But it also spreads out that myopic defocus across a very wide area of roughly 30 degrees around either point of the fovea. And so that's very beneficial for your myopic patients. And here again is a slightly different handout that talks about the differences between the different designs that are available. And if you look at this particular one right here, this one here shows what happens if you have a 6 millimeter pupil. And you're going to get the 6 to 8 diopters of plus power in the natural view lens here. And on this one here, you're going to hit the first ring of the plus power in this concentric design, which is only 2 diopters in this situation. Now, if the pupil becomes smaller, let's say it becomes 3 millimeters, as I talked about before, then you are not getting to the reading power, the plus power in this lens. So you have no benefit. Here, with the natural view multifocal, if you get to the same 3 millimeter diameter, you're still getting 2.5 diopters of plus power. So in the case of a youngster who is outside playing, getting the 2 hours a day that they need to help keep myopia in check, you're still going to get a benefit from wearing the lens. Contrast that to the concentric design, and you're getting no benefit whatsoever. So that creates an issue with that particular lens type. Now, an area that is often talked about And it is a concern because so many people do have some astigmatism. It's something that is addressed very nicely with the design of natural view multifocal. And a lot of it has to do with the way that this lens works with spherical aberration in part to create the EDOF channel. And so what happens here is very similar to what happens for your presbyopic patients. Your two different meridii for the astigmatic eye create two different focal points along the visual axis. If those two focal points fall along the EDOF channel created by the natural view multifocal, then that astigmatism is going to be corrected, not just masked, but corrected. And it works the same way that it works for presbyopia. In fact, the two can work together. So if you have a presbyope with lots of astigmatism, you're going to get great vision because you're correcting both entities at one time because of this EDOF channel. And we have FDA approval in the United States for up to 2 diopters of astigmatism. But we have recent results from a study that was done by Dr. Carrasito in Spain that shows that we can correct even more than that with the natural view multifocal. His study design was pretty straightforward. You had the low astigmatism group, medium astigmatism, and high astigmatism group. We had 4 visits, or they had 4 visits, and they looked at the high contrast by distance binocular visual acuity, stereopsis, subjective visual quality, and subjective overall comfort. In the groups, we had a fairly even spread, and all of the different parameters, with the exception of the cylinder, were virtually identical across this demographic. As you would expect in the different astigmatic groups, the amount of astigmatism that we were addressing was different, but everything else was virtually identical. The lens was the same, natural view enhanced multifocal that is out on the market currently. And you can see that the power range is +4 to -1225 in quarter diopter steps. And that's important because you want to be able to give every patient precise distance vision. In that study, when they looked at the low and medium astigmatism groups, they found that they were able to get 20/20 or better vision in 100% of the subjects that were participating. 2015 was or better was available to those patients with up to 2 diopters of cylinder for 67% of the participants. And when you go to the next group down, the higher group, up to 3 diopters, 83% of the participants had 20/20 vision or better. And a third were 2015 or better, which says something about how well the design works. And you can see that the acuity is very, very good. Another way to look at that is to look at a distribution graph, but you see the same things here. You're able to take care of 83% of your patients between 3 and 2 diopters. And once you get beyond 2 diopters, virtually 100% of those patients are getting 20/20 vision or better. So the lens will work as well as a toric without all the complicated toric fitting issues. And when it came to stereopsis, it was preserved at spectacle levels, and there was virtually no difference, certainly none that was clinically relevant, between the spectacle and the natural view multifocal wearers. So overall, the study demonstrated that the lens can effectively correct up to 3 diopters of cylinder, and that 83% of those patients get 20/20 vision or better. 77% rated their overall visual quality as satisfactory or very satisfactory. So we had a lot of very happy patients in this study. And stereopsis was preserved, and it works well with all pupil sizes. I'm going to talk about that more in a little bit. So, in conclusion for the study, they found that unlike traditional toric optics, the natural view multifocal corrects the extended range of astigmatism by enabling both meridians to be focused at one time. And it validates natural view multifocal's astigmatism correction indication easily because, again, 100% of patients up to 2 diopters in this study had 20/20 vision. And there were no adverse events in this study. Data from this study is summarized on the third page of the Protect RCT fact sheet, which we'll discuss a little bit further in a moment. But this is, again, available through Lena. So the big talk, pretty much every meeting you go to, is myopia progression control. And we know that the desired treatment effect is to bring all of the peripheral light rays inside the retina to decrease the stimulus for axial elongation. So that is the goal. And that's what we are trying to do with the natural view multifocal. The other thing that we need to do is make sure that the vision and stereopsis is normal for these youngsters because no matter how well a product works, if it doesn't give youngsters or even presbyopes vision that they're comfortable with, they will not wear it. And if you're not wearing it, you're not going to get the effect. In a study done with 20 subjects, we found that the vision between best corrected spectacle acuity and the natural view multifocal was virtually identical. The only place where there was a little bit of a glitch was in the low contrast, low illumination distance vision, and that amounted to just a couple of letters on a line difference. When it comes to stereo acuity, there was no difference between the two groups. And what they found when it came to lag of accommodation was that lag of accommodation was improved by wearing the natural view multifocal contact lens. And that has been borne out in the Protect study, as we'll talk about in a bit. Now, VTI has always been a revolutionary company, and they did things a little bit differently because in the beginning, there were a number of practitioners using the lens for myopia progression control, and some of them started talking at a meeting and realized that they were having similar results. So they decided to group all of their information. And what they did was take 15 different practitioners at different offices around the country. They submitted all of their data for youngsters wearing natural view multifocal, not just the ones that were successful, but all of them. And that data went to an independent statistician who looked at everything and came up with the results. And what they found was that the lens was able to basically keep myopia from progressing uh, more than a quarter diopter across the board for about 6 years, which is unbelievable. The Treehouse Eyes people did their own study to look at their algorithm for how they're treating myopia progression control in their population. Part of that study looked at their use of soft multifocals, and some of them were natural view multifocal lenses. And it turns out their results were very near the results from Jeff Cooper and colleagues in the six-year retrospective study. At around the same time, an ophthalmologist, Dr. Carrie Letterman from New York, was presenting data from a small study that she was doing in her practice that looked at these youngsters wearing natural view multifocal, and lo and behold, her results were virtually the same. Now, the gold standard for clinical studies is a randomized controlled trial. And a lot of people around the country and around the globe took issue with the fact that we were using retrospective studies. The difference between the retrospective study and the RCT is that the RCT will show you what to expect in the real world. The retrospective studies show you what's actually going on in the real world. But to address this issue, VTI began the PROTECT study, which was randomized control. There are 8 centers in the United States, Canada, Hong Kong, and Singapore. All of these patients had to be treatment naive, so they could not have had any other myopia progression control spectacles, contact lenses, ortho-K, or atropine, because that could be a confounding factor and make the results look better than they really are. So they were out. It's a double-masked study, so the subject and outcome measure examiners have no idea who is wearing what, at least initially. And because of concerns about the ethics of having youngsters that we know are going to progress and have negative outcomes with myopia progression in a study like this, they biased it so that 2/3 of the participants were wearing the test lens and only 1/3 were wearing the control lens. And at the 24-month mark, all of the control subjects were transferred to the test lens. And what they were looking at, of course, was the change in cycloplegic spherical equivalent refraction, change in axial length, and of course, safety. You can see from this chart here that the demographic breakdown for the test group and for the control group were virtually identical. And that's what you want in any kind of clinical study. When you look at the baseline refractive error and the baseline axial length data for each of these different groups, again, you see that they are virtually identical. At the 1-year mark, there was a planned interim analysis, and they also did a subgroup analysis of enrolled subjects who met a common myopia control study criteria, and that being youngsters aged 8 to 13 with a cycloplegic spherical equivalent refraction of -75 to -4. At the 1-year mark, 14 subjects had exited the study. 6 were voluntary, which gave a dropout rate of roughly 4%. And all available subject data was included in these analyses. Looking at the safety results, there were no differences between the two groups. Vision, distance and near, was virtually identical at 1 month and at 1 year. Unadjusted and adjusted treatment effects when it comes to myopia progression are shown in this chart. And you can see down at the bottom of the blue box that the change, when you make the adjustments, was very, very similar. A 0.41 diopter change unadjusted and almost a 0.48 diopter change or treatment effect with the adjusted data. But if you look at the line above that that's got the red box around it, you can see that in the adjusted group, the amount of change was virtually nil, a 0.056 diopter change with the natural view multifocal from what it had been with the control. Pretty impressive. And if you look at axial length data, you see the same thing. The adjusted and unadjusted data is virtually identical with a 0.17 care value in each of these groups. And that's important because we know that axial length change is one of the biggest things that triggers the myopia progression. So we want to keep axial length as small as we can. And with the natural view multifocal, as you can see in that group above the blue box, the change was basically 0.126 millimeters, which is roughly the same as what we would get in your emmetropic patients. If you look at a distribution graph of this data, you can see that 64% of the population had a quarter diopter or less change in their myopia progression in that year, which is pretty impressive. A quarter diopter or less is considered insignificant change. And yes, of course, there were people that did change by more than that, but you would expect that in a study as large as this one. If you look at axial length, you'll see that 58% of the study population had a less than 0.125 millimeter axial elongation, which, as I said before, is equivalent to emmetropic growth. And of course, yes, there are some that had more than that. But again, that's to be expected in a study of this nature. Now, the 2-year data has just started to be looked at. And one of the preliminary findings here was that the natural view multifocal showed a very good effect still at keeping myopia from changing very much. The adjusted treatment effect at 24 months is now 0.60 diopters, which is a 53% decrease in myopia progression. But if you look over at the axial length side, you'll see that the axial length treatment effect was actually almost identical to what it was in year 1. And it now reflects an 86% decrease in axial elongation from the control group. That's pretty impressive. And that, again, is the big factor. We want to keep axial length as small as possible. Now, as I said before, if a youngster is not going to wear whatever intervention you're using to try and help them with their myopia, then you're going to get zero effect. In this study, participants were required to wear the lenses for at least 10 hours a day for at least 6 days a week. And what they found when they looked at the wear time schedules was that most of these youngsters were wearing them between 11 and 12 hours a day, 7 days a week. So obviously, the vision and comfort with the lens were significantly improved to the point where these youngsters were able to wear the lenses all the time. And again, as I said before, there is a Protect fact sheet. This is the latest version. This actually is a 3-pager, and the first 2 pages talk about the Natural View Protect study. You can see on the left side towards the bottom that it shows we get a continuous effect for treatment across all pupil sizes. And that was something that was being looked at in the study. And it's very encouraging to see that no matter what size the pupil is, you're getting a treatment effect with the Natural View multifocal. And that is a really big benefit for this design. So just in summary, the Natural View multifocal is definitely a safe and effective way to manage myopia. The subjects found that they had great satisfaction with the comfort and vision of the lenses, so that it was very similar results between the single vision control group and the multifocal test group. And because the lens works over such a large range of pupil sizes, you don't have to worry about decreasing your treatment effect if the pupil size becomes very small or becomes very large. And at the 2-year analysis, we found that there was a 53% reduction in myopic progression and an 86% retardation in axial elongation, which again is critical for keeping myopia in check. And one of the other things that they found in this study was that the high plus in this lens actually reduced accommodative stress. People that had large accommodative lags seemed to become more normalized. People that had accommodative lead seem to also become more normalized. And as Ashley pointed out to me yesterday, the people that had a normal accommodative status had no change in their accommodative status because of wearing the natural view multifocal. And so that is an important thing because there's always concern that the patient is going to stop using their own accommodative system and allow the contact lens to do all the work. And that simply does not appear to be the case. Now, I said before that presbyopia and myopia probably had around the same number of people that need help. And that is very true. So it's an area that we do not want to ignore in our populations in the practice. And we talked about pupil size before, and pupil size is important in some designs of a lens because if you have a very small pupil, the patient can see really, really well to read, let's say, but it gets progressively worse as you go towards distance because they're not hitting the distance zone in a progressive aspheric design. If the pupil gets large, those patients can see and they can read basically 6/6 or 20/20, but they'll tell you it's not clear. And that's because they're looking through the edge of the optic in the design that they're wearing. So it would be nice if we had a product that really didn't need to worry about pupil size with, and that would be natural view multifocal. The natural view lens in our early preliminary study back in 2015 found that best corrected spectacle acuity and natural view multifocal acuity were within 2 letters of each other at every distance. And interestingly, with the natural view multifocal, it was 2 letters better at intermediate. So we're getting great vision with this whole population. Stereo acuity was also preserved at near spectacle levels with the natural view multifocal. And it did not matter whether it was a younger presbyope or a more mature presbyope, the results were the same. There is, of course, a handout that summarizes a lot of this data. And we're going to talk in a moment about how to fit this lens because that's an important factor. But if people follow the fitting guide, you will basically end up 88% of the time having the first lens you try be the last lens you need power-wise. And that is a huge time saver in the practice. Now, again, this is the study slide that looks at the defocus curve study that we did. And again, you can see that the functional vision area, the area under the blue curve, is much larger than it is with the area under the orange curve, which is your spectacle baseline. And again, this was a 2 diopter increase in depth of focus for these patients while wearing natural view multifocal. So it can be a significant benefit to your mature presbyopes, but other studies that we have done have shown very similar results across the entire age spectrum. So it's a true universal ad. If you have, let's say, a 40-year-old patient with a plus 125 ad, and you have a 70-year-old patient with a plus 250 ad, if their distance power is the same, they'll wear the same natural view multifocal contact lens. So there's no need to concern yourself with what the patient's ad is. The need is to make sure you get your distance vision as sharp as possible. So kind of a quick summary of what makes natural view multifocal different. For one, it's a center distance extended depth of focus design. There is nothing else like this that's on the market today. And maximizing distance vision is what we need to do to get the clarity that we seek. The catenary curve power profile creates a true universal add. So your emerging presbyopes and your advanced presbyopes can get the same quality of vision. More importantly, if you keep that emerging presbyope in your practice year after year as their reading needs change in their spectacles, you will not need to change the contact lens power unless the distance part changes. And that's very important because it's a huge time saver if you don't have to make adjustments and try to figure out which compromise you're going to use as you would need to do in a traditional concentric design. So that's one time saver there. You also have the universal astigmatism correction. And the lens will correct, not just mask, but correct up to 3 diopters of cylinder based on the study done in Spain. And that, again, is a time saver because toric lenses require a lot more work to get quality vision. And if you now incorporate a multifocal into that toric design, you have an exponential increase in the time that it takes to get a good result. And lastly, it's relatively pupil independent. So across the normal spectrum of pupil sizes that the population exhibits, you're going to get clarity because the optics of the lens will not be significantly affected by pupil size change. Now, I've said a number of times that we need to fit this thing a little bit differently. And while it's true that it is different, it is not difficult. You're basically going to pick the same type of presbyopic patient that you would pick for any other lens. You want somebody that's symptomatic. They want to wear a contact lens. And if they're a current wearer and not happy with what they're wearing, then you've already got a very good basis to start. You would like to have a normal cornea, so no keratoconus and no refractive surgeries. And again, astigmatism of 2 diopters or less is going to be no problem whatsoever. Now, just to backtrack a little bit on the normal cornea thing, two things that have been brought to my attention by different practitioners. One is that in early keratoconic patients, the natural view multifocal actually seems to work very well. And this is all anecdotal, and I've only heard it from maybe a half dozen or so practitioners, but people are trying it in different situations, and it seems to work. Again, the cornea in someone that's had refractive surgery tends to be very flat centrally. And for that reason, most soft lenses, including natural view multifocal, are going to vault that central area. So you do want to try to avoid those people, at least in the beginning. It's interesting that I did a fitting seminar at a practitioner's office out in, I believe it was California, and we had them bring in 4 or 5 patients so that we could demonstrate to the head practitioner and his associates how this should be fit, and then they could try different ones. Well, the first patient that they brought in for me to fit was a woman in her early 60s who had had refractive surgery, LASIK, about 10 years earlier, and she was not happy with having to wear glasses. Her prescription, if I recall, was minus a half at 180 in both eyes. And I prefaced the fitting by saying, this is not something that's likely to be super successful, but let's give it a try. Well, long story short, she was 20/15 or 6/4.5 at distance and N 4.5 at near. And I had her hang around while we did the other patients just to see if it would be different after she had adapted to it longer. And it did not. After a couple of hours in the office and doing different tasks, reading, checking email, etc., her vision was still 20/15, and she was happy as can be. So it can be done. It's just not the place you want to start. And when it comes to your younger myopic patients, basically every myopic child is a candidate because we know that if the myopia continues to increase, there's going to be stretching to the retina, which in later years can lead to a number of problems with retinal tears, detachments, myopic maculopathy, posterior subcapsular cataracts, etc. And I know that every practitioner will have their own sensitivity level for when a youngster should go into some kind of intervention. For me, it was when the prescription was not age appropriate. So let's say you have a 7-year-old child in the chair, they should be about a +1.25, maybe a little bit more. But if they're not, if they're a +0.5 or they're in the minus group already, you need to start treating. And 7-year-olds can handle the lenses. That's not an issue. So never let that worry. Now, in the past, and I hear this a lot from different doctors, we have been pushing plus because the center near designs that are on the market force practitioners and patients to compromise. So we have to push plus at least on the non-dominant eye to try and increase the near and intermediate vision. When you get to a certain point, that starts to become a negative because it starts interfering with distance vision. With natural view multifocal, you maximize distance vision, and that's the only thing you need to consider. The way to do that is to do your best distance refraction, and then you're going to bias towards minus. The reason we do that is because there is plus power that creates proximal accommodation because rooms are very short nowadays. Gone are the days where you have a 20-foot or 6-meter exam lane. With rents and whatnot in buildings now, that's simply not possible. So they're all shorter, very often using a mirrored system and now using computers to produce the images. And all of those different factors can create plus in your system. Add that to the fact that the natural view multifocal design starts building plus power 5 microns from the distance center. So there's plus in front of the pupil right from the get-go. So we need to bias towards minus to get that focus on the fovea as precisely as we can. And fear not, this does not over minus your patience. You would have to significantly increase the amount of minus in front of the patient before there was an effect. In fact, there were studies looking at how exodeviations can be treated using higher minus powers in patients. And what those studies have found was that you needed to get to 2 diopters or more of extra minus above what's needed for distance in order to start seeing any effect on myopia progression. So a 1/4 diopter or a half is not going to create an issue. Think of it as a fitting factor similar to the Jessen factor used with orthokeratology. Now, once you have that refractive data and you're 1 click into the green, you put all of that information, including all of the cylinder power, into the NatraView Quick Start Calculator. And the Quick Start Calculator will vertex correct for you, and it will round in the right direction. As an example, if you have a 0.75 diopter cylinder, and you're taking half of that to create your spherical equivalent, you have a 0.375 power that you need. Well, that's not available in any contact lens or spectacle. So you either go to a -1/4 or a -50, -0.50. With NatraView multifocal, you need to go to the -0.50. You need to bias towards minus. The calculator app does that for you. So it's automatic. And I would behoove you to use the app either on your phone or on your desktop with every patient, not just the ones that need vertex correcting, because it will, again, round towards more minus when you need it, and that will give you the proper starting powers almost every time. So to summarize, it's really very straightforward. Best correct spectacle refraction, either do the duochrome test in the dark so that you get the chromatic aberration issue as well. And then you put that total spherocylinder endpoint into the Natural View Quick Start calculator. And you're basically trying to get to the point where you're fitting this as if it was a single vision distance lens and you're getting your distance clear first. Now, once you've calculated those lenses, you need to allow the patient to adapt. Every multifocal out there will tell you to let the patient adapt at least 10 minutes. Some, it will say at least 20 minutes. And what's happening with the Natural View multifocal is that the brain and visual cortex are learning how the neurofocus optics creates the images versus what they might have been wearing before. So they need time for the brain to de-adapt from whatever they were wearing before. Let's say it was a center near design, and then to adapt to the Natural View multifocal's neurofocus optics. And 10 minutes is usually enough to get that going. If you can let them wait longer, that's even better. But don't assess distance vision for at least 10 minutes. And what I always tell people is set a timer. We are notoriously poor at judging how long something has been that we're waiting for. I did a fitting seminar somewhere, and we fit one of the practitioners with the lens, and I set the timer on my phone. And after about 3 minutes, one of the other practitioners said, "Okay, let's check that distance vision. It's been time." I held up my phone and said, "Nope, 7 more minutes. Got to wait." And in that time, the person that was wearing the lens was commenting that, distance vision looked kind of fuzzy to begin with. But by the time we got to that 10 minutes, she was going, "Wow, this is so much better than it was when we started." Now, after they've had the lens on for 10 minutes and you assess their vision, I used to like to ask my patients that were old enough, do you think that you would be comfortable driving with the vision that you have right now? And if they said yes or no, I would say, all right, can you rate your vision on a 1 to 10 scale where 10 is fantastic and 1 is garbage? And if they gave me an 8 or better, I was usually pretty happy. If they said it was a 7 or less, I was not so enthused. And at that point, I would turn on my distance chart and see what they could read for me. And very often it's a good idea to start with larger letters and have them move down from there, because the visual system will still be learning and they will notice that, yes, it was a little struggle in the beginning, but now it's getting much easier. And if the patient says that their vision is a 7 or less, or they're a little shaky about the 8 that they're claiming they have, change the power on the dominant eye by a quarter diopter more minus. There's no reason to over-refract. It just wastes time, because the optics of whatever lens you're over-refracting with are not the same as the EDOF optics of the Natural View contact lens. So very often, if you held up a minus quarter in front of the eye, the patient might say, "I don't think that's any different." But if you change the lens on the eye, they will instantly say, "Wow, that's better." So it's worth doing that. It's a time saver, again. And don't be afraid of the quarter diopter change in either direction. Listen to what the patient is telling you about their vision and go from there. As you can see from this dramatization, at 0 diopters, which is dead on power-wise, the vision is pretty clear. If you go a quarter diopter in either direction, it starts to degrade. And the further you go, the worse it gets. So with this design particularly, a quarter diopter can make a significant difference in how the patient sees. So make the change on eye with a different contact lens power, and your patient is going to be much happier quicker. Now, patient education is the key. This lens is totally unique. There's nothing like it out there. And you don't need to go into heavy specifics with a patient, but I used to like to tell them that this lens is going to actually make your brain do some work in your visual system. And so it's going to seem a little strange in the beginning, but it will improve as you adapt to this lens. And I also like to tell them that while the distance vision might look good, it may seem a little bit odd. And very often we get people that say that their peripheral vision is a little hazy. And that's the brain adapting to the EDOF optics of the lens. And that goes away after a few hours to a few days, depending on the patient. When they're in the chair, after you fit them, try to discourage looking at distance. The near and intermediate are generally great right from the start because there is so much plus power in this lens. So let them check emails, let them read a magazine, whatever, but keep the distance chart off. And again, assure them that as you move forward, adjustments can be made if they're necessary. The bottom line is you're already doing most of this. It's different, not difficult, because we're biasing towards minus. The time you spend up front getting the fit down by basically getting that distance vision where it needs to be will decrease the amount of chair time you need in subsequent visits. You're going to use the same fitting steps for your presbyopes and your myopes. Myopes tend to be a little bit easier because they don't have a need for near and intermediate vision. And that makes it a little bit simpler. So if you've fit a couple of myopic patients and gotten this good vision, you'll understand that by maximizing distance vision with the presbyopes, you end up getting the same clarity at every distance. And again, when it comes to adaptation, it's different, but again, not difficult. The brain will adapt to these optics very quickly. I mean, it took me, I think, 2 or 3 days to adapt to this design. And I was coming from a center near design where I was struggling with my near. And when I increased the add power to the high add power that was available, it didn't help my near, but it surely hurt my distance. And switching to this lens looked kind of odd the first day. Day two, it seemed much more natural. By day three, I forgot that I was wearing anything different. It was working great. So talk to the patients, let them know what to expect, follow the fitting guide, and you're going to be in good shape. And as we saw before, the lens comes in +4 to -1225 powers, and a quarter diopter steps the entire way. So if you need a 975 or a -1125, you have it. And that's important because, as we showed before, a quarter diopter can make a big difference in how the patient evaluates their vision. You don't need to worry about the ad with this lens. There's more than enough power to get whatever you need for any presbyopic patient. As we said before, it generates 6 to 8 diopters of plus power at a 5.5 to 6 millimeter core diameter. For FDA purposes, we stopped it at +3, but it will easily go beyond that. The base curve is an 8.3, diameter is a 14.5. That helps to ensure that the lens centers well and does not decenter hardly at all. But don't worry about the 8.3 base curve thinking that it's too tight. The lens actually drapes the cornea more like a lens that has an 8.6 base curve sagittal depth. So it's really not as steep as that number appears to say. And again, it comes in 10-pack trials, so you can let the patient use it for a week in the real world. It's a daily disposable, which is a very safe mode. And studies have shown that the silicone hydrogel is not really superior to the hydrogel when it comes to the number and risk for corneal infiltrative events, etc. And the safety profile is well established. And numerous studies have shown that. And Loretta Schottke Flynn and colleagues have looked at the oxygen flow through etafilcon and other hydrogel materials versus some of the silicone hydrogel materials. And their conclusion was that there is no benefit to a silicone hydrogel lens on a daily wear basis. The silicone hydrogel lenses do have a leg up when it comes to extended wear, but this is a daily wear only product, and it's discarded at the end of each day. So you do not need to be concerned about oxygen flow or any oxygen related issues with Etafilcon A in the natural view multifocal. And with that, I will thank you and show you the my contact information here. If you have other questions later on, I'm always available to answer questions. And now our technical requirement, the indications for use in the United States. You'll notice that it's for the correction of refractive ametropia and or presbyopia in patients that have a reading add of up to 3 and astigmatism of 2 diopters or less. Internationally, we have that same indication plus myopia progression control. And that's important to know if being on label versus off label is of concern wherever you're practicing. And that is all I have.
Thank you so much, Doctor. A lot of key points after this presentation. I mean, just the universal ad that you were explaining and reporting, the centenary curves, the calculator that you just showed us, being able to download the calculator using ISO or Google, that will be a tremendous help for our practitioners. Great presentation. Thank you so much. We are going to stop recording right now.